Let us all wait for a couple of minutes and allow all the participants and attendees to join in. Hello everyone, welcome to our webinar announcing the finalists of the Upjeevika Telemedicine Livelihood Challenge, an initiative supported by DXC Technology. We would now like to officially begin this webinar. We will be initially talking about the idea and the concept behind Upjeevika and what it strives to attain with its methodology. It would be followed by DXC representatives talking about their philosophy of innovation and the commitment to enable nascent social innovation via Upjeevika. The two finalists shall then be talking about their solutions, making a case of their unique offerings as well as the impact they aim to achieve. We will conclude by announcing the next chapter of the Upjeevika challenge. You can send us your questions via email or write them in the box below, and we would be happy to answer them with a detailed clarity. Now, without wasting much time, let's invite Dr. Gayatri Vasudevan, Chief Impact Officer at Samba Foundation, to talk in detail about Upjeevika and the purpose behind it. Samba Foundation believes in creating infinite possibilities to change the lives of women, youth, and the differently abled by empowering them with the right set of knowledge, skills, and linking them to sustainable livelihoods. Upjeevika is a key initiative by the Samba Foundation that identifies promising social enterprises and supports them to scale up and grow in their domain.
The reason we started Upjeevika was there is a need in the not-for-profit sector. We believe that the not-for-profit sector and the social enterprise sector are two sectors which are critical in the coming decades to ensuring people have livelihoods and people have social security. Both are important to live a happy life. Unfortunately, the not-for-profit and the social enterprise sector haven't seen the kind of major collaborations and innovations to solve local problems. Whereas if you look at the for-profit sector, we see India has emerged as a beacon of light. We see, if you look at today's newspaper, it says that the amount of funding which is coming to startup India is the second in the emerging markets. So the intent of Upjeevika is to start collaborations and conversations that the not-for-profit sector is able to bring together. The pandemic showed us and not only this pandemic, but if you look at any crisis, the not-for-profit sector and the civil society seems to step in considerably to solve emergencies. But when there is a long-term emergency, as in employment is dipping, wages are falling, poverty is increasing, I think the question really is who's working on it? Are there solutions which we can creatively come together? And that's what Upjeevika is. It is a collaborative effort. It is not an ownership of one organization. So we've been very, very, I would say, grateful to a number of people to have come together to make it a reality. So there have been right from the our sponsor who took a major leap in faith to start something like this. DXC, our sponsor, for us to do that, and at the same time, we have a whole lot of others who are looking at social innovation. They're looking at it from the perspectives of domain sometimes, from the perspective of platform sometimes, but at the same time, it's very important. And I'd like to really invite others to think through what will result in people earning a livelihood and ensuring that all their lives, during their working life, post their working life, they are able to live a dignified life. I think that's what Upjeevika is looking for. Today, when we look at a life of an individual, it starts with birth, and obviously it stops with death. But this period of time is heavily stratified. Um, uh, you know, at all points in history, class has made a difference as to where you're born, and therefore what would you have opportunities for. But I think in today's environment, with the opening up of the of communication, infrastructure, education, health, the opportunities that are there are enormous. But at the same time, the challenges have become have actually overpowered us in some manner. So one of the things that we've been looking at in Upjeevika repeatedly is to say, what does resilience mean to an individual? And we have defined resilience from livelihoods, from the perspective of livelihood, because we feel that if a person earns a living, he or she is able to support a family. Now, where does a person earn a living? Obviously, it is in their economy and various sectors which are booming. So when we look at it from that perspective, there is always ups and downs. Certain sectors do better in a decade, and certain sectors do worse in a decade. So we've tried to pick sectors which have a possibility of employing more people, and possibility of looking at a service. Now, let me take an example here. The first sector we picked was healthcare, because obviously it is care, and there is only this much automation which care can do. After that, you need humans. Therefore, employment will always be a necessity in this sector. It will never be a sunset sector. Healthcare will always be a sunrise sector from an employment perspective. Whether state employees, civil society employees, private sector employees is a different issue, but the need for care will never go. So we thought that's a very important one. Now, the question really is, does the healthcare sector provide dignified livelihood? Does it provide resilience? Are the people in the healthcare sector doing jobs which you and me consider as absolutely important, and without it we cannot live our lives? Do they get paid enough? And who pays the people who actually work in this sector? Do the companies, are they private sector companies? It is state responsibility. Does the state have enough money? If not, does civil society have to step in, and do sustainable models have to come in? Do completely different models have to come in? Like microfinance was a model which came in to plug the gap where banking could not reach. So is there a need in the healthcare sector for a similar transformational change to happen? And that's what the first challenge was about. In the health sector, we decided to focus on two roles, the community health worker and the auxiliary nurse midwife. The reason that we did it is that what is evident is that access to good healthcare, primary healthcare, particularly in rural communities, seems to be very, very distant. Having doctors, nurses, specializations is just not seeming to be possible in the next 10 to 20 years. The two layers which are present today, the community, the ASHA, which are part of the government system, and the community health workers, who are largely part of the not-for-profit sector system, seem to be the first layer which is creating awareness. And at the medical level, it is the auxiliary nurse midwife, who is often connected to maternal health, and the primary healthcare center seem to be the other role which is available today. It is not to say that other roles cannot be created, but we thought, let's play on what roles are available and create a mechanism by which they are able to serve the community. Now, serving the community means ensuring that all issues related to primary health, whether it is communicable diseases or non-communicable diseases, we are able to either identify and treat early. So it doesn't really catapult into a crisis and an emergency situation. Given that our tertiary healthcare system cannot be overburdened, so can we actually strengthen the community preventive health as well as, to some extent, primary curative healthcare? So the Upjeevika challenge, the first challenge, we got a lot of response from young innovators, entrepreneurs who were interested in solving this issue. This came because of the several partnerships that we had from important collaborators who actively participated in ensuring that we got the responses that were needed. For the innovators and challenges, what we hope to bring, apart from some form of capital, is mentorship. Can they get mentorship in different areas that will sharpen their thought process and lead them to become possibly the next social enterprise or a not-for-profit which solves problems which are at this point almost look like no one is really looking at. Right when we started Upjeevika, we were lucky to get a lot of people backing the whole solution. So the jurors are the first that come to my mind. All of them are very, very respected and successful in their spheres. So we picked, and we have the innovators have the opportunity. The jurors come from different backgrounds, right? From policy to technology, retail, federations, industry bodies, and academia. For us, the jurors played a very, very critical role. They spent time in looking at each solution. They spent time in evaluating why this solution could really change and be a game changer. While each of the solutions and each of the innovators and entrepreneurs who applied for it was unique, and we believe that each one of them had scope, we had to actually pick the best amongst them. Or at this point of time, I wouldn't even say best, it is those who, checkboxed what we were looking for. So the jurors really helped in this, and I'm eternally grateful for the amount of time and energy that they put in the selection process. So the jurors were able to really select innovators and entrepreneurs who had potential. Each one of the entrepreneurs and innovators were unique in their own innovation and challenge that they are at this point handling. But at the same time, the jurors look to see who has the most potential and how can the jurors themselves help them grow. I think that was the perspective that they took in the selection process.
Thank you, Dr. Gayatri, for your insights on Upjeevika. We would now like to invite Mr. Karthik Iyer, Director Business Operations GIDC India at DXC Technology, to talk about DXC's core philosophy of innovation.
COVID-19 opened our eyes to the disparity in access to healthcare. 71% of India's population lives in non-urban areas, but only 34% of the doctors practice there. This varies by region. Anywhere between 25% and 75% of these doctors may not have a formal qualification at all. To bridge this gap in equitable access to healthcare, telemedicine presented the cheapest and the fastest path. Additionally, it presented the potential to create new livelihoods in every part of India. The Telemedicine Livelihood Challenge focused on two key areas: the inclusion of community health workers, especially ASHA workers, in telemedicine to serve as community mobilizers and improve the acceptance of telemedicine in rural areas. The development of multi-purpose health workers and auxiliary nurse midwives, ANMs, as telemedicine service coordinators to facilitate the conversation between doctors and patients. To enable this called for rapid social innovation. When applications closed on 16th of July, 70 innovators started the journey of evaluation. The impact they created, the sustainability of their solutions, the potential to help telemedicine take root while creating new livelihoods were all evaluated over multiple rounds. We have now arrived at 2 finalists from the 70 who started this journey. We hope the Upjeevika ecosystem is able to serve their mission and more such entrepreneurs and innovators can make the best of this unique platform. Thank you very much.
Thank you, Mr. Karthik. We have your colleague, Ms. Angeline Jayaseelan, Associate Director HR at DXC Technology, to share more about DXC's vision of enabling social innovation in India.
Hello, everyone. I'm Angelin Jayaseelan, and I lead corporate social responsibility at DXC Technology. Corporate social responsibility is one of the core pillars of our organization, and it has been DXC's mission to support and develop our communities and give back to the society we operate in. The ongoing health crisis has led us to reimagine the way we perceive life and livelihoods. As part of our ongoing commitment towards improving the lives of those who are underrepresented, we are proud to collaborate with Sambhav Foundation to launch Project Upjeevika. At DXC, we believe in leading from the front and meeting innovation challenges head on. So it was a natural choice for us to support Project Upjeevika. DXC Technology is proud to be the platinum sponsor for Upjeevika's first ideathon, the Telemedicine Livelihoods Challenge. Upjeevika aims at reimagining the livelihoods of India's informal sector. This is to be achieved through a series of innovation challenges designed to identify and support social enterprises with the potential to create resilient livelihoods in India. Towards this, we invited individuals and teams to propose livelihood solutions for problems identified based on in-depth ethnographic research in the first sector, which is telemedicine. We had a jury of experts who, after rigorous evaluations, have identified best-in-class ideas. And these winning ideas will get the opportunity to access Upjeevika's ecosystem and expertise. We are happy to see the finalists present their ideas in today's session. As next steps, Upjeevika will arm innovators and change makers with actionable research and invite them to ideate collaboratively and prototype sustainable, scalable livelihood solutions. Innovators with solutions that show high potential will find the support they need to move from a promising idea to a sustainable societal change. As I wrap up, here's wishing our finalists the very best in their endeavors, and we look forward to more participation as we launch the next challenge. Thank you.
Thank you, Angeline and DXC team, for being a key pillar of support for this initiative. We would now like to move ahead and bring the spotlight on a finalist of the Telemedicine Livelihood Challenge, Ubicare Health Private Limited and ZMQ Development. Please welcome our first finalist, Mr. Subhi Qureshi, Chief Executive Officer at ZMQ Development.
Hello, my name is Subhi Qureshi. I am CEO of ZMQ Development. ZMQ Development, or ZMQ as it is called, is a technology for development social enterprise. We are set up as a not-for-profit organization and we work in the areas of livelihood, education, health and other sustainable issues. In the areas of health, we are working in multiple domains, and they are infectious diseases, maternal child health program, mental health, and non-communicable diseases. In the area of communicable diseases, we have taken up TB as one of the key areas to address with solutions for the last mile communities. We specialize in building last mile technology linked development solutions for unreached communities, poor, underprivileged, and disconnected people on the ground. As we know, TB is one of the biggest infectious killer disease in India, and that is the reason that made us look into TB to provide solutions to the people and the communities on the ground. And this is the reason we came up with this whole model of PACT, which is actually patient active care and treatment system. PACT is a very comprehensive solution designed for TB patients, primarily patients in the remote settings, poor settings, underprivileged communities, and people who do not have access to the main health system facilities. It was designed so that the patient is able to manage his or her own health remotely over a mobile device. That TB is the largest killer disease, infectious killer disease in the world, and India has a burden of over 24% of the total global burden, and we see a lot of patients dying of TB every year. Over 450,000 patients die each year in India. Similarly, globally also. And during the COVID, we saw that there was a 60% downfall in the TB case notification, and that was primarily because people could not connect with the health system. So this solution, although was designed before the COVID period, is now proving to be very successful, and we are right now piloting this program in Mewat, one of the low resource districts of Haryana, an aspirational district, and also in Uganda and Rwanda. And we are seeing very encouraging results where we are able to see that a remote counseling center, which is based in Mewat, is also catering to patients in Uganda or in Rwanda or in other parts of India. We are trying to address the sustainable goal of health, where TB is one of the key components. Eradication of TB, or the NTB program of WHO, is designed to end TB by 2030, where we should have less than one patient per 100,000 population. And the Indian version of this NTB program, which is called TB Mukt Bharat, which was actually flagged off by the Prime Minister, Mr. Modi, to end TB by 2025. It is it looks very challenging, but it is a positive step towards eradicating TB. And the telemedicine system that we have developed for TB program will ensure that we are able to accelerate this whole thing, because the patients will have access to treatment in their pockets, in their hand. Key component, which is the premium component, or the component of adherence to treatment management, follow-ups, and all the other key components of related to TB treatment plan and TB treatment regimen, are all free to the patients. They are provided to the patient so that patient can report, at least align with the DOTS program, so that they are able to report their daily adherences. They are able to ensure that the treatment is going on in time. They are able to take medicines in time. They are able to connect with the health system in time. But the second key component, which is remote consultation and counseling, where counseling is a free service, which is where we have selected 3 sets of treatment supervisors who counsel patients over a video call with the patients from the toolkit designed for the patients, is free. But the other component, which is right now free and is being supported by a grant that we have received for the program, but it is as a pilot grant, it is about consultations, because during the course of treatment, a lot of complications, side effects happen with the patients, and patients have no access to a health system to reach out to an expert or a doctor to take an advice. So we have built in this remote consultation system, where a patient need to pay 10 rupees to 20 rupees per consultation, or take a consultation plan of 100 to 150 rupees for the whole period of treatment, and cover all free access to health experts advice and health experts. And also the health experts can reach out to the patient if in case they see that the patient had problem and is not able to. So there's a two-way connect on this device, on this tool, where both the patient can call in the doctor, and the doctors can call in the patients, and the whole transcript is recorded and is saved and is converted into a text transcript, which is saved and then shared with the patient and other health facility providers. Last but not the least, which is the capacity building tool, or we call it as the value added services tool. Here the patient need not pay anything, but we have a model whereby a lot of organizations were looking to provide non-commercial communication or public health communication to the patients. They can use that channel to tell stories, to tell health information, and so on and so forth. And this is a ever-growing channel. We launched a TB storyteller an year ago, and right now we have over 100,000 subscribers of that TB storyteller, which is an independent toolkit. But this toolkit is also built into the patient toolkit, and it is in tune with the patient timeline of treatment. So if somebody is in the early stages of the treatment, the stories or the content that is delivered to the patient is specific to that particular period. And when it moves to the continuous care phase of the treatment, then there are different kind of communications and tools that are provisioned to the patient. I would like to highlight the unique feature of the PACT program, and the unique feature of PACT program is that it is designed for last mile communities. It is designed for devices which are low resource. In low resource setting, it works in 2G environments. It need not have 3G because the telecommunication that we are holding is low resolution, because it's not the quality of the video that needs to be looked at. It is the quality of communication that is happening between the doctor and the patient, and the quality of reporting of adherence that is happening. And a lot of digital optimized solutions are provisioned to the patient on his devices, on their devices. And we are looking forward to scaling up this whole strategy under a program called adhere.global, where we are thinking of establishing a universal platform where anybody in the world who is on TB treatment or TB-like treatment like leprosy or other bacteriological infection diseases can take up this kind of take up our solution and start adhering with all the models connected, the adherence model, the counseling and consultation, remote consultation model, and value-added services. Because the value-added services component may look least important, but it is of prime importance, because we are talking about patients who are low literate, who do not have much communication in hand about tuberculosis. So all the three components are very important, but the key design, which is designed for the last mile, for the people who cannot read and write, is the key feature of this the program that we have developed. I would like to thank Upjeevika for selecting and shortlisting us as one of the finalists. We are very happy to be part of this program. In fact, we were referred by somebody to look into this program and apply under Upjeevika program. And as we were selected, all our team, which is working in the area of tuberculosis, and all the other team members are very excited about this program, which opens new doors for our PACT program to take it global or scale it up and make it a success. The interaction was very simple. The forms, everything that was asked was simple and very easy to fill, but they were very precise and concrete, and it turned around in very quick time that we are here and talking to you, and hopefully we are going to take this program to a next level with support from Upjeevika, as we understand. And thank you, the team of Upjeevika, for trusting upon what we are doing and taking it to the next level. Thank you very much.
Thank you for letting us know more about ZMQ. Now let's welcome our second finalist, Mr. Sridhar and Mr. Srinivasan, co-founders at Ubicare Health Private Limited.
We enable specialty medical care to patients at home. We founded Ubicare in late 2017 with that mission of enabling specialty care. We recognized as a specialty medical care provider in Bangalore for complex illnesses. Sometime back, a couple of months back, Status Insights has recognized Ubicare as one of the 5 top palliative care solutions impacting healthcare globally among 191 startups. We received recognition from BIRAC, CCAN, and KSAP Bio50 program. Our innovative care model has been presented in a paper in IIPCon in February 2020, and also has been covered in few press articles.
We are addressing the long unmet opportunity of extending specialty care from hospital to home. The annual disease burden of non-communicable disease is quite high and is increasing with longer life expectancy. We estimate this to be around 280 million per year based on IHME data. Many of these diseases are life-limiting in nature and require a long post-acute care period ranging from a few weeks to even years. A typical patient journey for any disease would be consultation and diagnosis phase, treatment phase at the hospital, followed by a long follow-up care phase. During this period, the patient typically prefers to be at home but suffers poor treatment outcomes and episodes of symptoms due to the disconnect from the primary specialist. And many patients switch over to a nearby doctor or hospital and are lost to the hospital. The specialty hospitals want to retain patients and stay in control over the patient outcome even after discharge. There is increasing demand from the patients too for improved health outcomes while receiving care at home, and hospital specialists are wanting to retain patients' trust and loyalty by extending care. The pandemic has only strengthened this need of patients and hospital specialists. We already see many hospital specialists adopting some form of teleconsultation or the other and offering home care to their parents. Okay, UbiCare addresses this need by offering its hybrid platform, MHAS. It is Mobility Healthcare as a Service or Managed Infrastructure. The UbiCare solution is hosted in the cloud and its various features are offered as a service. The platform is a multi-tenanted cloud-based platform with an underlying electronic health record, patient-centric access, and integrated interactive audio-video chat. The platform is a care delivery platform as against a teleconsultation platform. The solution offers access to medical expertise, protocol-based care delivery, and physical touch to remote patients through last-mile clinical network. Its features of care continuity, support for protocol-based workflows for specific illness segments, collaborative messaging, training, coordination, and supervision of last-mile physical interventions fulfill the major requirements of specialty care extension. It incorporates illness-specific care protocols and derives care workflows to suit the patient. Such a techno-clinical extension brings continuity of care to the patients and offers control over patient outcomes to the specialist. It supports collaboration among partner clinicians to provide prescribed services. Using this collaborative platform, specialists and duty doctors in a hospital extend complete care to patients at home, including supervised physical interventions.
We have actually been providing this right from the beginning of our incorporation. So from 2018 July onwards, we have been going on providing services through our platform, and the platform is indeed proven and in use. We have enabled care for more than 350 plus patients with over 15,000 patient days of care using the solution ourselves. We have received excellent testimonials from patients and doctors. Last year, we have actually gone ahead and enabled a multi-specialty hospitals with the platform so that they can deliver care to their COVID patients at home in both the first, they also use it in the second wave too. The hospital has onboarded several specialists in the platform and has migrated over 4,000 plus patients and has done over 2,500 consultations in the last few months. It has also delivered care to over 200 COVID patients in the first and second wave. We also launched this in Mysore, and right now we are actually having RFPs with several hospitals. So what the traction primarily is, we have actually gone ahead and done services ourselves. Plus, we have also enabled several hospitals to reach out, and that's what is really shown in the figure.
I will also link it up to the impact that we are making, because that sort of fits in very well. So with this solution, and as proven by the various the many days of thousands of days of care that we have given, this solution actually brings to the patient and the kin reduced hospital visits and improved care outcome, to the specialist control over the outcome, and the patient and the hospitals the ability to retain patients. But the economic impact is also very, very high. It actually provides increase in livelihoods for many primary healthcare workers in the last mile. Right? It cuts down, it makes the healthcare more affordable, bringing this down to $5 to $12 per day of expense. It actually enhances the care quality significantly. It avoids more than 90% hospital visits, and more than 50% of healthcare journey is managed away from the hospital. Just extending this our end development goal would be to enable a large community of doctors, specialists, and hospitals to reach out to remote patients. The care pathways and configurable workflows that we are hosting and will continue to build would ensure high quality of personalized care to remote patients across various illness segments. And last but not the least, the hyperlocal clinical network would positively impact the livelihoods of the last mile healthcare workers. So this three constitute the end development goal, which we call it as virtual follow-up care extension.
What we are doing in a solution is sustainable. We are leveraging the existing clinical capacity of clinicians, healthcare workers, and healthcare organizations using a collaborative model. Hence, it increases the possibility of a success rate, primarily because we are participating and encouraging the collaboration among the existing set of features and extending the specialist care. We will also have increased payload of economic activity, as the solution is actually is a one-stop solution where more than 80% of the specialty care are being taken care for patients at home. The total cost of care, as Sundar already mentioned, is reduced to 3x to 5x times, and more than 90% of the clinical interventions are managed at home. This makes sustainable. And what makes us unique is the fact that we are offering, like I said, virtual care extension from hospital in a subscription as a service model, a platform as a service model. It primarily enables hospitals, specialists, as well as the other healthcare workers, organizations to come together. Whereas specialists extend their own protocol, they will be able to retain the patients, and the ability to manage interventions through this collaborative network basically makes it very unique. And that's what actually we are providing. In the market, for example, there are several people providing different kind of solutions today. And if you look at primarily somebody who's focusing on the hybrid care, virtual care, with coming physical, is something which we look at the possibility of actually extending and enabling specialty care to patients at home. And that we don't see many are actually there.
The theme of Telemedicine Livelihood Challenge resonates very strongly with our mission, because our mission has been to bring in a collaborative ecosystem and technology to extend care away from the hospital, where a lot of healthcare is concentrated and therefore it's out of reach for many people. So that resonance was one thing that made us really jump up, and a lot of our some of our existing shareholders and investors also pointed to this, saying, hey, this sounds like meant for Ubicare. Yeah, so that's one thing that I wanted to say. And we are also excited by the promise of Upjeevika connecting us to the relevant ecosystem to build this last mile.
And this is, it was very nice to interact with Upjeevika, and primarily the aim of actually using what you call a whole ecosystem, and where we can actually utilize the existing healthcare workers and healthcare organizations together, which also, like you said, Sundar, resonates with this theme of Upjeevika. Actually makes a lot of sense, and that has been a great motivator for us too. So thank you.
Thank you, Team Ubicare. It was a pleasure to understand your efforts and goals for creating an impact in the world of telemedicine. We would like to wish the best to both of you. We would now like to welcome Dr. Gayatri Vasudevan once again to introduce the next challenge in the Upjeevika cycle, the Logistics Livelihood Challenge.
The success of the telemedicine, more than the telemedicine, the health sector challenge that we had, we launched the second challenge in the logistics sector. As you're well aware, the logistics sector and the e-commerce sector have seen an explosion of jobs. There are a number of people who have come into this sector and are gainfully employed. But the two roles we thought were very important was the intrastate commercial vehicle driver sector, which faces a significant shortage, while the need for long-haul movement, given the improved infrastructure in India, is now a reality. So we look to see what could create jobs which are dignified there and which are resilient, and what kind of solutions are important there. At the same time, intra-city jobs in the logistics sector have also exploded with the door-to-door delivery across sectors, be it at the rural area, at the agricultural product and commodity sector, or in the urban area, the food delivery sector, the grocery delivery sector, door-to-door, goods delivery sector, everything has boomed. And therefore, we felt again, given the jobs there, are they dignified jobs? Will they have social security? And these questions are actually plaguing us. So the everyday narrative of it, we're seeing play out in the newspapers and policy discussions as how much should state interfere and how much should private sector do, and what is the role of the not-for-profit sector in ensuring that service is available at everyone's doorstep equally, and the people who are delivering it, are they actually resilient livelihoods? Are they decent work? Those of you who know innovators and entrepreneurs who are working in the logistics sector, primarily, as I said, solving issues which are related to either delivery or driving, please do apply here or point them to apply towards the Upjeevika platform. I think this would be an opportunity for them to actually grow their thought process and contribute to the nation.
Thank you, Dr. Gayatri, Mr. Karthik, Ms. Angeline, Mr. Sridhar, Mr. Srinivasan, and Mr. Qureshi for your time to be a part of this insightful webinar. We are proud of the success that Upjeevika's Telemedicine Livelihood Challenge has turned out to be, and we wish the same level of success for the upcoming Logistics Challenge. We would also like to thank all our attendees today for being a part of this webinar. We shall be sending out the recording of this webinar alongside answers to your questions on your email addresses that you have used to register. We would look forward to seeing you all once again. Thank you.